So this is a very interesting topic of refitting IOLs and back complexes. Can you connect? So this is all about dislocated IOLs. My course, thank you Amar, Gaurav is joining, Rohit, Om Prakash, Namrata can't make it. But I'm going to show an interesting video of, we do face this situation. Yeah Gaurav, please come up. You're there, Chitra? Yeah. So we'll start this course. I'm Dr. Kumar, doctor from Mumbai. So every year we decide what more tough cases we are going to do. So every year we have a new resolution coming up. So you want to enjoy life, get fit, get a better job, take a trip, lose weight. So everyone has their own resolution every year. So I decide as we get more and more experience, we do face tougher situations. And then what are the other options? Now this was a very interesting case. You can see that he's fishing an IOL. So this patient was operated by me about 25 years back. Details of the old surgery are not there, so I do not know which IOL is there. B scan was done, and on the indirect we can make out that there is an IOL, but you can't see the design of the IOL. Specular, no history of trauma, plan the action, and what are our options? One option is to explant the IOL which is already there, re-implant another glued IOL, or do a posterior iris fixation. And you'll see what I did is very interesting. And you may have never seen anything like this before. So you can see that the IOL is missing and you can't see the back complex. So this is known in some scenarios where the whole thing is missing. And once in a while, if you move the eye, obviously there's a block, you can see something moving, but you can't make out what it is. So of course go ahead and put your trocar. Once you've done your trocar, you have to plan, right? So you have to plan as to how are you going to go about this. So I decided that let us measure. First thing is to get your white to white. And I thought that I will do a glued IOL. And thanks to Amar, who is with me here, who's the inventor of many things. Like how we make a list of awards we win, he makes a list of inventions he does every month. So this is making the flaps for the glued IOL, which is very crucial and important step. And I made one side pot, okay, and then I'm making another side pot. And then of course there is vitreous in the AC, we do staining. And to my luck, the 3-piece foldable IOL, not foldable, the 3-piece IOL comes up. And I immediately grasp it with the micro grasping forceps, okay. Now, some of you may not have even seen this kind of an IOL. As you can see, this is a 6.5 millimeter optic with dialing holes. In olden times, the optic used to be larger and there used to be dialing holes in that. And you can see it's a J haptic. It's not modified J, it's not C, it's not modified C, but they are large haptics and they are J. And you can see that I've got the IOL completely in the anterior chamber. But if you notice, the angulation of the haptic is not correct. It is in the opposite direction. So this is one haptic and this is the other haptic. These are the dialing holes which used to be made originally, and that helps you to put the IOL in the bag. That's why they were invented. So now I am flipping this IOL in the AC itself. Now why have I done that is so that the J comes in the right orientation for me to glue. Another thing is these IOLs are non-foldable, so you can't cut them. And another thing, they had a 10-degree angulation, so I could not have left it upside down. Once I have done the flip, I just go ahead and then do the glue technique with a handshake technique. But in these cases, you have to be very careful because these IOLs and haptics are extremely brittle. They are not as malleable as the new generation IOLs. You saw that a large haptic portion comes out and then go ahead. So here what is the take home message is that the same IOL, so no need for calculation, refitted through 2 side pots with an MVR, and we glued the same IOL back and the patient did extremely well because it's his own IOL. At the end of it, just put the glue and go ahead. So refitting is better than explanting, no need for a larger incision. Older design, as I mentioned, newer design IOLs are much easier to hold, and this will make the IOL stable forever. Now this is another case where you will see a patient with a uh, same large optic with a 6.5 millimeter and subluxated, again put in a trocar, make the glue. And this case we decided you can't use a Malugan ring. Remember this, if you have a small pupil, don't put a Malugan ring or a B-hex ring. You have to use hooks because that only will give you enough exposure. So once you use the hooks, you can then remove all the vitreous that is holding on to the IOL and bring the IOL up in the same direction as that is necessary. And once this is done, you can see that once go ahead and then put it. Now this you can see that the same lens which was subluxated is now brought up, and make sure that all the traction of the vitreous all around, in front and behind and around the IOL is removed. So use the same port to do the vitrectomy and remove it, make it free, and this haptic can be held gently. Always hold the tip. So again, this is a handshake technique. Hold the haptic, go through the underneath the flap. Once you've done that, remove that hook because that's not necessary. Hold the haptic, go in through underneath the flap, and always make sure that you hold the tip of the haptic, and that will really help you to bring the haptic out. And once that is out, you can just glue it. So same story, again a subluxated IOL refitted. Now this is another case, again a subluxated IOL, but you can see a posterior capsule and an anterior capsule fused. Now this pupil does not dilate, nothing happens. So again same story, if it does not dilate, you can't use a ring, you have to use hooks because that gives you adequate exposure. Once you got your adequate exposure, now the question is, it's a 3-piece IOL. These are the new generation IOLs, and I want to not remove it because I can refit it. So what I'm doing is centering the IOL, making sure I mark the center on the visual axis, and then I go ahead. Now you have a fused anterior posterior capsule. You can see the fused anterior posterior capsule here. Once that is done, I now just do a little bit of vitrectomy there and make sure that I make a little opening. Now how do I make sure that this same IOL which had subluxated does not again subluxate or dislocate? So I'm doing an optic capture in the fused capsular complex that is present. So I'm just now nudging the inferior part of the optic inside, and then I'm nudging the superior optic inside and making sure that it goes ahead and just stays. So this way the optic capture has happened in that opening that I made in the back complex, and this will always remain well centered forever. Just one more case I will show. Again, this case was operated by me many years back. It's a twin set bifocal IOL. Some of you might not have seen this IOL. And this patient, you can see the rings down, you can see a nice pupil. Patient is allergic to Topicacil Plus. When you dilate and see, this is all that the pupil really dilates. And you can see one nice round opening in the center, and that's a YAG opening. Now this is a multifocal IOL which is subluxated, and obviously the patient wants multifocality. So what are our options here? Let me show you that. So this is a YAG opening. You can see a beautiful nice round YAG opening. So again, under topical anesthesia, you can see a subluxated or a dislocated IOL, okay? And this is a bifocal IOL. I put intracameral epitrate and the pupil beautifully dilates, and you can suddenly see the two haptics. This is known to happen in this IOL. I've had 3 cases like this. For those who have used this IOL, they know about it. So one haptic that you can see here is in the fused back complex. One haptic is anterior and the optic is lying free. Go ahead and put triamcinolone on, make sure that you do the vitrectomy, and then coming to the explantation of the optic, you have to make sure that whenever you want to explant any optic, use the incision as a fulcrum, micro-grasping forceps, cut the optic. You don't need to cut through and through till the other side, just cut half of it, so 3 millimeter, and then I'm just going to hold the optic and use the incision as a fulcrum, so that you can just remove it. Once you just hold the incision, hold the optic, just rotate it around the incision and remove it. Once that is done, as I mentioned, one of the haptic is floating free in the sulcus. That can easily be removed. The other haptic is sitting nicely between the anterior posterior capsule. Don't bother, just let it be there. It's not going to come in your way. Don't forget, this patient wanted multifocality. Now what to do? So that's the next question. Go ahead, do your vitrectomy. Then use a 3-piece multifocal IOL. No financial interest, this is available, and put this IOL in the sulcus. And again, the question is, this 3-piece multifocal IOL should never dislocate or subluxate. again do an optic capture in the YAG opening that was there, and this will always maintain the centration of this multifocal IOL, and the patient will be quite happy for a long time to go. So these are some of the cases that I have shared. I have a fantastic panel with me, Chitra, Amar, Gaurav and Rohit. I invite Dr. Chitra, you ready? Dr. Chitra to give her presentation. So this is all about subluxated IOLs and back complexes. Thank you very much.
इसमें नहीं है, ये नहीं, इससे नहीं चाहिए हमको, फुल नहीं चाहिए. सॉरी सॉरी, ये पुराना है.
Dr. Chitra Ramamurthy, yes, you're ready?
I'm so, I didn't know.
No problem. Amar, you want to Amar can take over. Okay, Amar, come this. You're ready, Chitra?
No, क्या कर रहे हैं, हमको ये पूरा देखना है, मूव करना है, इसमें नहीं चाहिए. नहीं, बंद कीजिए, ऐसे नहीं चाहिए हमको, क्योंकि ये पुराना है.
When you have Amar in your course, it's always Amar because you don't have to worry about it. He always asks me, how much time do you want to cover? You give him half an hour, 1 hour, 1.5 hours. We are secure.
Thank you very much, Kumar. Can I have the video?
अभी कैसे पता चलेगा?
Yeah, okay.
I'll be talking about
So let's see.
I have those videos, I don't know.
This is the first case which I thought I'll show you. And can I have the video there, please? Can I have the video on the top? Yeah, okay. Now, if you see this patient, my doctors were operating this patient, and then they suddenly called me. I said, are you guys joking? You want me to operate this patient now? Look at inside. I can't see anything. And inside it, there's a dropped IOL. There is bullous keratopathy, hazy cornea, but most important, see the ciliary staphyloma. On top of all this is the only eye of the patient. Okay? So it's a one-eyed patient. I said, let me see what I can do. And now you can see, so first thing is, I do not know where the pars plana is, and I have to be very careful in such situations. So what I decided now was, first fix a trocar AC maintainer. Once I fixed my trocar AC maintainer, I made my flaps, but look at the flaps, they are not 180 degrees apart. So I decided to make them 180 degrees apart. Here you see, I'm making a fresh flap. Once that's done, I now know I have to go in and lift the IOL. The problem is that ciliary staphyloma is the scary portion for me here. Because if I mess up that area, I can tell you one thing, there's no way I'll get out of it. That can start bleeding, and it's a no-win situation. My second problem is, can I see through this cornea? Obviously, it's very bad. I've taken off the epithelium. There is bullous keratopathy, but you can see the haze, and you can see the IOL lying on the retina. Once I've done a vitrectomy, the technique which we started by Ashwin, is called ECAL. What we do is a very simple technique. If you use a forceps to lift, you can produce a rupture of the retinotomy. So what we do is, we use the suction. Once we lift it by a suction, as you can see there, then I transfer it to a forceps. Through that hazy media, I've lifted it up. Now I've caught it, and trust me, if you are not seeing anything, don't worry, even I am not seeing. The worst part is, if you notice, this is a very tough lens to fixate, because as you will realize, it is a single piece non-foldable IOL. Now when you try to glue a single piece non-foldable IOL, it's very tough, because if you bend a little bit, the haptic will break, and if that breaks, I have to explant. And if I have to explant, please understand, in this eye, I don't have any space to explant, because on the top you see the ciliary staphyloma all over. So I have to be very careful now. When you do such cases, please understand, a 3-piece IOL you can just flex and tuck. In a 1-piece non-foldable IOL, you have to withdraw and then tuck, which is what I am doing right now. So here you see I have created the Chariot's pocket, and there I am tucking the haptics in. So far so good. Now my next step is, I need to make this pupil smaller. So I am doing the single pass 4-throw pupillasty. The media is very hazy. The media is very hazy, there is no doubt about it. So I am using an endo illuminator from outside. I want to do some more of the 4-throw pupillasty, so that I know I land up with a bit of a pinhole pupil. So here you see you've done one on the one stop, one below, which will make my pupil much better. So simple technique of single pass 4-throw pupillasty is being done. Now once you do that, now I'm taking my vitrectomy probe, and I'm going to make that pupil with a vitrectomy probe bit decent and nice, because my main aim is, one, to make the size correct, about 1.5 to 2 millimeters. Second, in this case is, more important, I need my Purkinje image bang on. When you get a ciliary staphyloma of this size, I tell you what, I have no indication or inclination of how much is going to happen in the astigmatism, how much of higher order aberration this patient will land up. So I need my pinhole pupil to work. So now you can see my Purkinje image, P1, bang centered on the pupil. Here, once you have done that, and my Purkinje image is bang on track, now my next step is to close that little bit of gap behind. Because please understand, if I don't close these gaps, the air which will be in the anterior chamber will go back through those gaps, because there is no capsule. It's only an IOL inside that eye. There's a space in the peripheral area, and the air will go down. So now through this hazy cornea, I'm doing some more pupiloplasty to close up that defect which is there in the peripheral iris area. Not for a visual effect that much, but more important because I'm going to do a graft now, PDEC. Now you see I've just shifted my trocar AC maintainer, which is having fluid in the eye, to air. In such cases, I tell you what, you will be much better off with a trocar AC maintainer than a pass planar, because here I'm seeing my trocar exactly all the time. Anyway, now I've got air inside that eye. I now take out my Desmaze. Now I create my bubble. This is a type 1 bubble. We do only PDEC in Agarwal's there. So basically remember, you have Desmaze, endothelium and the Duas layer. It's about 25 micron. Then the air comes and stroma. So that's a type 1 bubble. The bubble doesn't go to the periphery. If it went to the periphery, it will be a type 2 bubble. But anyway, coming back to this particular case, once I prepare this graft, my next step is, I have the Sublux IOL, I lifted it up, fixed it. Now I take this graft after the pupiloplasty and I'm injecting it and unrolling it. Remember, ladies and gentlemen, this is the only eye of this patient. So there is no second chance for me, I know, in these cases, because it's going to be very tough to make this patient all right. This is the pre-op, one-eyed patient. We did the ECAL, we did the glued IOL, we did the 4-throw pupillasty, we did the pinhole pupillasty, and we did the PDEC. And now look at the same patient, pre-op, 1 month post-op, and you can see how the patient looks. So that's the first case which I thought I'll show you. Now I take you to another case. And let's see in this particular case how the situation goes. Now in this particular case, there was a small pupil. So this is an eye ring. It is made of polymethyl methylate, and you can see this. This is like a modification or of the Malugan ring. So I use this inside. It's green color. So look there. I'm using trypan blue for staining the capsule. But somehow I have not noticed my rhexis has run away. Now once my rhexis has run away, I have not noticed it at that stage. I say continue with the phacoemulsification. You don't have to be an Albert Einstein to understand rhexis has run away, hard cataract. With my surgical skills being so bad, I will develop a PC rupture. When I develop this PC rupture, as you can see just now, obviously the next step, there's no rocket science to understand, boom, gone, nucleus gone. So now the question is, I have a nucleus drop, obviously. Now question comes, what do I do? So you can see the rhexis has extended posteriorly there. So now I am in big trouble. I have a drop nucleus present. I have an eye ring present inside the eye. The next mistake I'm doing is I'm doing an IA, which I should not be doing. I should have gone for a vitrectomy system because there's obviously vitreous coming. So I now fix my infusion cannula. Now a simple trick which I tell all of you when you have cases like this, just follow a simple trick. And that is very simple. I start praying. Okay? If you start praying, like I'm doing right now, and I'm doing my vitrectomy, and you pray and pray and pray, and you see my nucleus coming up, caught. The problem as a human being, we tend to get arrogant. So I stop praying. And when I stop praying, you see what happens is basically this. Once it drops. So answer, again start praying. So now again I'm starting to pray, and now you'll notice that nucleus again come up. Now I'm not leaving it for dear life. I'm bringing it on top. The thing is, how do I remove this nucleus now? So we thought, let's do the scaffold technique, which we published in the year 2012. And here you can see I'm using the 3-piece IOL, holding with the left hand the nucleus fragment. And you can see we first published it in the JRS, Journal of Refractive Surgery. Later on, we published this in the Ophthalmology Journal, where the basic principle is you bring the nucleus up anteriorly, implant the 3-piece IOL behind the fragment. Now, use the phaco probe and emulsify. If you have a rhexis, you can just put it in the sulcus or glue it inside. So once you see that IOL inside there, the next step for me is, you can see there, I'm now going to use the phaco probe and emulsify the fragments there. So this is the IOL scaffold technique. Once that is done, now my next step is very simple. I have to simply transfer the haptic which is above the iris to behind the iris and glue it inside, and I should go home. The problem here is I did not realize there is an eye ring. So watch carefully now. My eye ring is getting locked. My haptic is getting locked onto the eye ring. So when I'm doing my handshake technique, it's getting locked. I'm not able to dislodge it from the eye ring. So I decided the next best method is to leave the haptic as it is. So now my one haptic is lying in the vitreous cavity. Now I'm going for the second haptic. I'm going for the second haptic now. Remember that if this haptic goes down, the case will be over because both my haptics will be down. So I'm doing this vitrectomy here, transferring the haptic from one hand to the other, catching it, pulling it out. So you can see the sublux IOL there, caught and pulled out. Once one haptic is out, now I'll do the same for the second haptic. So here you see catch it somewhere, transferring it from one hand to the other till you get the tip of the haptic caught and pulled out. So far, so good. Now my problem is to remove the eye ring. The thing is, when you do a removal of an eye ring or any of these rings, first dislodge them from the iris. Then you can pull it out. Here what I've done is I'm trying to pull it out without dislodging it from the iris. In the bargain, you'll notice in a second, here I'm trying to pull it out and I've created an iridodialysis. This is like going from the frying pan to the fire, and you can see here, now I've created a big iridodialysis. So now my next problem is, what do I do? So now I'm trying to dislodge the eye ring from the iris, from the pupillary margins, then I will try to remove it. Now in the bargain, if you notice, what's happening is, my eye ring is started to go down. And with that, if you notice, my haptic on your left is also getting nearly going back inside. So now I've got a multiple problem here in my hand. One, my eye ring is going down. Two, my IOL is again starting to sink. So I'm trying to bring that eye ring anteriorly, and when I'm trying to bring it, it's still not listening to me that much and going in posteriorly. So the next step for me will be to catch that, the haptic which is about to go down. So my assistant grabs it, I catch the eye ring before it goes down any further. Now what I have to do is bring this eye ring anteriorly out. Once it is out, bring it above the iris. Now I take the same one which I used to inject it to explant the eye ring. And you'll see me doing that just now in a second. So here you can see I'm using the same injector and I'm explanting this eye ring out. Once my eye ring is out, remember I lost my haptic again, so I'm making more of an anterior sclerotomy to get more haptic externalized. Here you can see I'm going to make an anterior sclerotomy. I already have an iridiolysis there, so I don't have a fear of creating an iridectomy there. I already have the iridiolysis. Now for the umpteenth time, again I'm going to catch that IOL haptic, catch it and pull it out. Here you can see me catching that haptic, pulling it out. Now all I need to do is tuck the haptics in. Before you do the tucking, please assess how much haptic is externalized. Look at the amount of haptic externalized, it's a lot. If that gets stuck, there's no way this lens will subluxate again. But remember, I still have to fix the iridiolysis. So the technique we have used nowadays is the trocar assisted iridiolysis, which is a modification of the hangback technique of Michael Snyder. So basically the principle is to use two double arm proline needle sutures from the iris to the sclera and repair it. Once my iridiolysis is repaired, now I will apply the air, check if there is any optic capture, pull out my infusion, apply the glue and seal everything down. That's the case post-operative day 1, ladies and gentlemen. And now you will see the same case 6 months post-op, the patient vision improved to 6.6. I'd like to thank Kumar for inviting me for this lovely course of his. Thank you very much, Kumar.
That was fantastic, Amar. I mean, you had the patience. I would have really got confused. I mean, the ring and then their iridiolysis and the lens going in. I mean, only you could have. I was worried in between. You'll ask me, what will you do, Kumar? I would have just said, call Amar. For me, it's very easy. But, I mean, every time we see his videos, there's a lot to learn. One thing is for sure that you can handle scenarios we are iatrogenic, and the way he shows them is unbelievable. So a lot of learning with that one video. Invite Dr. Chitra Ramamurthy, who needs absolutely no introduction. She's going to talk on subluxated cataracts, unfortunately, because of some confusion. But anyway, they are tough cases, so we'll get to see more.
Very good afternoon to one and all of you. And I seem to have misread the topic, and I'm talking on subluxated cataracts. But anyway, it is about how we stabilize the bag. So basically, when we talk about bag stabilization, it's very important for us to estimate what is the kind of zonular weakness it is there, based on which we are going to decide on a plan of action, whether it's mild, moderate or severe. Now that becomes something absolutely important, and what we see on the slit lamp is not at all necessarily the exact plan of action we take, because on the table you might realize that the area of zonular weakness is a lot more. Again, the way you are going to stabilize the bag depends on, one, the degree of zonulopathy. It also depends on what is the underlying pathophysiology, because if it is a trauma induced, we need not be so obsessive, because we could take a more easier approach. But if it is a pathological cause or a progressive kind of zonulopathy, we need to get more aggressive. So it's very, very important. The very basic tip is that this is a very elastic bag. So there's a pseudo-elasticity because of the zonular weakness. So first you place a highly retentive cohesive viscoelastic, initiate the rhexis away from the area of the dialysis. Sometimes once you have initiated the rhexis, you could place capsule retractors to stabilize in that area and then go on to complete your thing. So this was a case of a loose capsular bag. You know, as I'm getting my nuclear fragment out, there is a tremulousness in the bag, and I decide that I have to keep my parameters low. My IOP is 40, but this is, now I would even keep it at 20. And so I keep my phaco probe right in the center. I ensure that my anterior chamber does not collapse at any point of time, and I keep injecting viscoelastic. But as you can see that I have somehow managed to do a sort of a supracapsular phacoemulsification, not in the bag. Now look at the bag, it's quite lax now. Would I place a CTR now? It makes sense to place a CTR, but I now fill it with viscoelastic and try to remove the cortex, because sometimes when the bag is lax and if you do not stretch it completely, you might actually catch the posterior capsule. So very gently, tangentially, I remove all the cortex, but I continue to inject viscoelastic every now and then, because sometimes, you know, when the CTR is placed, getting all the cortex is a little more trouble. So this was the way I dealt with it, and I was lucky enough, largely because there was no area of zonular weakness exactly, just a loose bag. So I was able to somehow, with injecting viscoelastic, stretching the fornices, stretching the posterior capsule, I was able to remove all the cortex, and then I go in and inject the IOL. Now this is a case wherein there is again on the slit lamp, I could not identify the zonular weakness, but as I start, I realized that somehow that tactile stimulus is not there. And so I think I initially make it a small rhexis, but then I find that I was able to get a centered rhexis and I enlarge it, and now it's always when you're not too sure about the zonular weakness, you need not immediately slip in a CTR, but I place capsule hook which will go and hold it at the equator and give that equatorial support. And then as I was shopping, I found things were quite okay and going good. But then there is that small area of zonular weakness. I would put another capsular hook there that pushes the vitreous back. So then with my low flow parameters, I start my phaco, but then I realized that at this point, somehow things were just not looking good. And I place my CTR into the capsular bag. Now the capsular hooks and the CTR are stabilizing the bag. So I now go on to complete my phacoemulsification. I keep my phaco probe right in the center and get all the pieces towards it in a very slow process with low flow parameters. And once the last piece is out, actually the parameters are very much brought down. But herein again, I inject the IOL now itself. There's still a lot of cortex in the bag, but the IOL is going to push the bag behind and then well away, and I'm not going to get the PC trampolining in, and then I loosen the supports, and then I remove my cortex and get out of it. So this is, I would show you, this is actually not exactly a case of subluxation, but it is how I'm going to stabilize the capsular bag is the point here. Here I make a Hoffman's pocket. There's just a coloboma, which means that the zonules are weak in that area, but in all the areas the zonules are okay, and actually these zonules are going to stay okay. So could have taken a very conservative approach. It's the important thing here is you need to place the CTR, because there could be a fluid misdirection in these kind of cases, but because it was such a soft nucleus, I have removed it with IA, and now I've placed my CTR, and I would always ensure that the eyelet of the CTR is well away from the area of zonular weakness. But then, what I think is, why not I further stabilize it with the Ahmed segment, for the simple reason, in that area of weakness, the bag is not supported. There could be an asymmetric bag contracture, and thus I deal with this. Now this is a case of actually on the slit lamp, there's a lot of phacodonosis, and I decide that I'm not going to be doing a phaco at all, and I'm not going to put two Ahmed segments. So this is what this kind of subluxation demanded, and it was a severe pseudo-exfoliative cataract. So I make a 3 o'clock and a 9 o'clock incision, and then I rarely ever do an SICS, but you know, these are those situations where you used to use your common sense and think which is the best way to bail yourself out. So I use a Vectis and I remove the entire nucleus with the bag out. Now it's a fairly small pupil here, so there's hardly any vitreous there, but I go ahead and do a shallow anterior vitrectomy. It's very important to do a good vitrectomy in these eyes because these are the situations where you can have a chronic inflammation post-op. And then through that incision, I push my iris clip lens. I've already got an incision at the 3 o'clock and the 9 o'clock. So just stabilize the optic of the lens and just you through the side port, I just push in some iris tissue through those pincers in the iris clip. Do a similar maneuver in the other eye. And this is just a pretty excellent way of going about it. Many would say you have to do a PI, but I believe if an anterior vitrectomy is well done, I would just continue to leave it at that. This was a patient who came to me rather, that he had already had a cataract surgery done and a CTR was placed in his eye, but he was having diplopia, and I found that his bag, IOL bag complex was subluxated, so I removed the entire IOL. But even as I was removing it, there was, the IOL was out, but then he had already told me that a CTR was there. Now that is something we need to keep in mind when you get patients who have not got the primary surgery done by you. So I go back and remove the cortical segment, but along with it the CTR came. Now if the CTR had not come in at that time, and I know there's a CTR there, I should have my posterior segment surgeon remove the CTR and not leave the CTR dangling in the vitreous, and then again I use my standard iris clip lens and bail myself out of the moment. Now this was a patient who had the whole IOL bag complex into the vitreous, and in this kind of a situation you have to do a thorough vitrectomy, remove the entire optic, and then as Amar had showed, this was just a simple Yamini technique in which the surgery was completed. Thank you very much.
Dr. Chitra, one question which I would like to ask is that you somehow do not fancy using capsular hooks in the initial stages. Why is this a non-preference, I would say?
Why would I not? Capsular hooks, if the, which stage? Capsular hook?
In the first case and in the
It
third
was
case.
first case was a loose bag. There was no zonular dialysis
It
at all.
showed some bit of...
No, there was no zonular dialysis right up to the end of the case.
And
it
in
was
the
just a
third
loose
case-
bag. All it needed was a CTR.
Okay.
Then the third case was second case I've used iris hooks. The third case was just a small area of zonular weakness wherein it was just a coloboma. I was just talking about how I was stabilizing the bag and I used a CTR and an Armand segment to stabilize it in that case. But if there is a bag is lax, the first thing I would do is to use a capsular hook because only that will stabilize right up to the equator. I would not think of using iris hooks at all.
Okay, great. And what are your indications for fixing the back to the sclera and or explanting the whole back? Because with the CTR there, in the...
Yes, that was a patient operated elsewhere, and he had come with the subluxated bag. So I removed the entire bag, and incidentally the CTR came along with the cortical remnant. So my message is that if there's a CTR there, sometimes the CTR could be in the vitreous. It's important that the posterior segment surgeon removes that CTR finally.
Yeah, I think you're right. I mean, there is no doubt about it. But at the same time, we have access to both. You showed a posterior iris fixation, or you can even do a glued IOL. So, 100% is now. I don't think any of us have used a AC IOL for many years now. Some
Actually,
of you may never get to see it.
for that matter, when we talk of ACL, although we are not doing ACLs in our place, but I think it is not to be thrown out into the dustbin for a simple reason. Those days we were not managing the posterior segment issues well. We were leaving vitreous behind and we were not measuring the white to white. No, I have not taking names. I've seen some good surgeons putting in an AC IOL in modern day in a rare situation. So, it is the AC IOL went into disrepute
So
because
if
of the
you-
primary surgery not being
If you
handled
take
well.
a vote of panelists, I'm sure none of us will put an
No,
AC
even
IOL
I wouldn't
today.
put.
So just a take-home message, yes, you can keep it like there was a time about 25 years back, you get a PC IOL and you get a AC IOL backup. So because sometimes you don't have AC IOL sitting there or you don't have a posterior iris claw sitting there and you have a complication, then what are you going to do? But of course in today's era with what Amar has invented as a glued IOL technique, you tuck in, the haptic is phenomenal. There is no wobbling of the IOL remains stable, always well centered, it's not going to go down. But remember friends, always you have to tuck that IOL. Without tucking, that IOL is not going to stay there. If you just put the glue and not tuck, the lens will fall into the vitreous. So that's one thing for sure. I now ask Dr. Gaurav Luthra to start his talk. I mean, everybody knows Gaurav. He got that Pearl Award from the AIOS committee yesterday. Brilliant anterior segment cataract refractive surgeon. He's been a dear friend for many, many years. Over to Gaurav.
Thank you, Kumar, and very good afternoon to everyone. And with a very interesting course, and it's like a specialized course by Dr. Kumar here. He also presents this course in the European Society and the SCRS as well. Very successful run courses there. So he wanted me to take out a few of these, subluxated IOLs. So I thought I'll just show some, after all those really complex surgeries from the top surgeons, I'll show you something straightforward and simple. So this patient presented to us with a decentered kind of, post. He had been operated elsewhere and had been, had an IOL which was slightly dislocated to one side. We could see a big PC rent visible to the side where the IOL had dislocated. And there can always be this vitreous which may be present. So one has to be very careful checking it. And if you have vitreous, then the first thing that you have to do is make sure that you've cleared all the vitreous out from the anterior chamber and with whatever is kind of surrounding the lens. And the surgeon who had done the surgery had been wise enough to put in a 3-piece lens, but incidentally, because the PC rent might have enlarged, so it had got dislocated. Now if he had done this optic capture, anterior optic capture, nothing would have happened. The IOL would have remained nicely in place, and all I had to do in this situation was just to clear all the vitreous and then just relocate this lens. I didn't do much, and you can see how beautifully it is centered. So it's just an anterior optic capture which saves the day, and no complex surgery is required. So sometimes the solution is very, very straightforward if you do it right and understand it right. Now this was another patient. You can see a small CTR eyelet here and an IOL which is dislocated. Now for this patient, apparently the bag was already slightly lax, and the patient had been operated a few years back, was doing extremely well for almost 7-8 years. She gives history of having gone to a doctor and got a YAG capsulotomy done, and post YAG capsulotomy she started seeing double, and her single piece lens which was in the bag with the CTR through that big capsulotomy. So the trick is to make a small central capsulotomy. That's all that is required. So if you do a big capsulotomy, the lens can, in such situations move about, especially some of the hydrophilic lenses are more prone to do that, but this was a hydrophobic acrylic. So we had a big PC break which was almost as big as that, and through that the IOL had gone behind the bag, and I thought I would again have to probably do something similar to the previous case, but when I went in I saw that there was no vitreous, I think, so we just had to hold it with a forceps. So here you don't need to use the dialer or the other instrument as I showed in that previous case. You can use these MST forceps which can be, so I just negotiated the lens forward. I didn't bring the haptics forward, again an anterior optic capture, because now the capsular excess is fibrous, so it's easy to capture a single piece lens. Otherwise it's not very easy to do an optic capture because they are posterior angulated lenses. So it's difficult to kind of do an anterior optic capture, but here the fibrosed rhexis was able to hold it nicely. The patient did well. There was very little intervention. So she had been told by several surgeons that you'll have an IOL explantation and a glued IOL and refixation and all that. And I finished the surgery in 5 minutes. She thought I'd done nothing, and she was not convinced that surgery was done. So this patient presented to us. You can see there's a CTR in the bag. The whole capsular bag complex has dislocated. I decided to refixate this bag complex. So we are making a Hoffman's pocket. Wherever possible, I don't dissect the conjunctiva. I just make a small groove at the limbus and dissect a Hoffman's pocket. It's quite elegant and it's clean. And the idea was to pass a suture through the. So it's very easy if you have a CTR in the bag and the bag is fibrosed. All you have to do is pass a suture around the CTR and then anchor it to the sclera. It's pretty straightforward. As you can see, I've passed the Prolene needle and railroading it into the bent 26 gauge needle. One suture is out of the Hoffman's pocket, and then I'm going to pass the second suture, and there goes. And once they're out, you will essentially have to just retrieve the sutures from the pocket. And one has to be very careful when making these pockets that they are of the correct dimensions, because if your suture is passed too posterior and not passing through the pocket, you will have a problem finding the suture later on, and then you can be in soup. So you have to know the landmarks and you have to mark out till what depth you have passed the Hoffman's pocket, otherwise there's a good chance that you will go wrong. So here, using a small manipulator, I have retrieved the 2 loops of the suture, and then all I have to do is just tie these sutures after snipping them. And once you've tied the suture and buried it into the Hoffman's pocket there, you just trim it, and it comes out quite beautifully, and the bag is refixated over there. And in the end, I do an OCT to see whether the optic is well aligned, and maybe put a little bit of pilocarpine and see if it centers well and the posterior capsule is clear in the middle. It looks good in the end, so that's how we leave it. Now, this was another situation where to begin with, it was a cataract surgery, and later on it became more of a surgery which required something which is the topic of the course today. So this was a pediatric cataract, and we started off by aspirating. This was very intumescent lens, so once I started the rhexis, I did some aspiration of the cortex under viscoat, and you can see that I am now enlarging the capsulotomy to the desired size. But in spite of all my efforts of enlarging the capsulotomy, I feel that we were left with a slightly smaller capsulotomy than what we needed. And I do try to aim for a 4.5 millimeters capsulotomy, because in pediatric cataract sometimes later on the capsulotomy will enlarge a little bit. Now, decided to go with a 3-piece lens as I would normally do for such patients, and the white to white was adequate, so I decided that this lens can go into the bag. This child was about 1 year old. So first thing that went wrong was that my haptic, which had gone into the sulcus, and I wanted to place it in the bag, I was having trouble retrieving it because it probably went to the edge and went through the zonules at some point. So when I tried to retrieve it, the bag was coming along with it. So there I should have switched to a forceps long before. The easy thing is to just go there and hold it with a forceps. A glue dial forceps would be just right, and just bring it, retrieve it. Here I'm able to finally do it, negotiate it into the bag, and then negotiate the optic into the bag. So the optic did go in after a bit of coercion, and now I want to put the second haptic. You can realize that the bag seems a little too small because the optic went in with difficulty. I'm trying to put the second haptic into the bag, but it's not going very easily. There's manipulation and it tends to just pop out. I decide to use a dialer or a Y-tipped manipulator to dial it in, and as I dial it in, I realize that something is wrong. There's a PC blowout because the IOL is too big for the bag. So now I have a dislocating IOL, which is now pointing, and I have a small rhexis through which I have to retrieve this lens. The rhexis is too small for me to manipulate it out very easily, and the lens, the optic has gone behind the PC actually in this area. It may not be visible on the video right now, but there's a big PC break like this all across. So what I do is, I now need to enlarge my rhexis. So I just give it a small snip because I want to get this optic anterior to the second snip on the other side. Found it difficult to make, so created a small another port, and now I have a rhexis which is about 5 millimeters in size. Now I'll go with the forceps and make sure that I'm not making mistakes, because this IOL can sink, and get the one haptic out, keep the lens stabilized, pass on to the other hand, and then using a second instrument get this thing anterior to the bag through the smaller rhexis, because the rhexis is still smaller than the size of this optic. So negotiating this optic anterior to the rhexis, changing hands, and now going from the other side with the glue dial forceps and getting the second haptic a grip on that, and now I'm secure. So I'll just have to dial that out and position this IOL into the sulcus. So you have to be prepared, and the correct instrumentation plays a big role. See, I'm now holding with the forceps and placing the haptics into the sulcus rather than trying to dial it in. And once that is done, now I have to do an optic capture. So putting in the second haptic now from the other side. So the IOL is now nicely sitting into the sulcus, but to lock it in, I'll just do a capture. The optic capture will happen fairly easy, and now the IOL is locked in. So you can, in pediatric cataract, it's not over till it's over, so you have, it can take time, but you have to ensure that you do a good job. And now the last video that I thought I'll share with you, if I still have time, this is something which was referred to us by one of the colleagues. He had a dislocated multifocal IOL of some kind. I think it's a Rayner multifocal of the older design, sitting on the retina. So of course it has to be, after vitrectomy you can retrieve it and bring it up with one of your hands, and then, since it's a straightforward single piece design, not ideal for the sulcus, but all you have to do is, you have a fibrosed capsular rhexis, you bring it anteriorly, and just, since it was, the other eye also had a multifocal lens, we didn't want to explant this lens and put in a monofocal lens, and it seemed much easier to just negotiate the lens and position it in the sulcus and see if it sits nicely. And yes, it did, and that made the task much easier, and the patient was also very happy because he got his vision back. And with that, I think I'll stop. It looked good post-operatively, and with that I'll stop. This is another one, but I think we've already covered much of this, so thank you so much.
Hello. Thank you, Dr. Gaurav. So now we move on to the next one, subluxated IOL bag complex fixation. So this is another way of putting things, wherein I would take up how we can prevent IOL bag complex subluxation and how we manage that. So we have to realize that there's an increased incidence of IOL bag complex subluxation, and the cumulative risk is 0.1% after 10 years and 1.7% after 25 years. So let's realize what are the basic fundamentals involved in it. The basic fundamentals we have to realize is that there is a centrifugal force by the zonules and by the haptic of the intraocular lens, whereas the concentric fibrosed ring around the capsular rhexis margin is creating a centripetal force. So whenever there is a disarray, we can have, whenever the centrifugal forces decreases because of weak zonules, we end up with a situation wherein we have that. So centripetal force is because of the residual anterior cuboidal lens epithelial cells, which undergo transition and differentiation, creating a situation where the cells get altered, which contains smooth actin. It undergoes contraction, and it creates a situation wherein there's a purse string contracture and constriction. So the mechanism which is involved is that there's a pre-operative, or a post-operative trauma or zonular weakness which decreases centrifugal force, and there's an imbalance of forces with less opposed centripetal force causing capsular contraction. We have to realize, and in these patients, like pseudo-exfoliation patients, there is progressive weakness and fragmentation of zonules, which ultimately leads to IOL bag complex subluxation or dislocation. So there are certain predisposition to zonular insufficiency and capsular contraction, like in more than 50% of cases, it's the pseudo-exfoliation, trauma, aging, high myopia, subtle zonular injury following previous vitreoretinal surgery or glaucoma surgery, retinitis pigmentosa, and there are many other factors which can cause this capsular contraction and ultimately leading on to subluxation of the IOL bag complex. Well, we have to realize that we can prevent it by some means. The first is, in all these patients where we are able to create a small rhexis, the first and foremost thing is we should try to enlarge the rhexis to an adequately sized rhexis. Now, what is that adequately sized rhexis going to do contrary to a small rhexis? What it is going to do is, it is going to decrease the centripetal force which is going to act. With the decreased centripetal force in predisposed patients, we can have lesser predisposition to an IOL bag complex subluxation later on down the line. This is another patient who has some bit of pseudo exfoliation. So in this, what I'm going to do is, I'm going to do anterior capsular polishing. With this anterior capsular polishing, we create a situation wherein there is less number of cells which are around, which causes decreased, propensity to form a concentric ring around the capsular access margin, which will ultimately decrease the centripetal force and create a situation where there is less predisposition of IOL back complex subluxation. This is something our own, Dr. Kumar doctor has shown, which won the video in the ASCRS, were the radial striae. And in all these patients where you see these radial striae, I'll show you again, these radial striae, all that you should know is that it could be because of some zonulopathy. So in these patients, if you put in a CTR, it can help us create a situation wherein we can, prevent or, decrease the chances of, IOL back complex subluxation. Moving on further is another step which can really help us is you can find that in this patient, the zonulopathy is obviously there. So in this patient, somehow I could complete the rexis without the use of any capsular hooks. Once that was done and the surgery completed, this is a trick which has been propagated by David Chang, in which you put the lens IOL in the sulcus and do an optic capture. So this locking of the bag, locking of the IOL decreases the propensity for an IOL back complex subluxation. Well, if you find in these patients, some patients, that there is an increased propensity to phimosis, you can do YAG laser, radiating so that the centripetal force decreases. So subluxated IOL back complex, if you come across these patients, you should definitely examine the patient in supine position. Because if you do not examine the patient in supine position, once the patient lies down on the table, you will find that it has gone beyond and it goes into the field of the posterior segment patients. So UBM also helps, no doubt, in telling us about the extent of zonular disruption. But you have to realize that with UBM, it's an imperfect device because it could miss subtle zonal abnormalities. So this patient had blunt trauma, decrease of vision, and there was diplopia. Dr. Gaurav showed, using 9O proline for that matter, railroading it. In this, what is difficult is, you have to go through, you have to use both your dominant and non-dominant hands, and you have to use difficult angles. And if the patient happens to have a deep set eye, you can have issues with, railroading it, and it becomes a slightly difficult position whatsoever. Nevertheless, I was able to do it, and you can find now once this is out, then you have to take the other one. One goes in front of the bag of the haptic, the other goes behind the haptic. So again, you take the 9O proline inside, and once you take it inside, you take the, the 26 or 26 gauge needle, go from behind and just lock it and bring it forward, and then you can railroad it. So this is slightly difficult with difficult angles, and depending upon, at times it's a non-dominant hand which comes into action. So this is something which does create issues for those who are not fully adept into it. And then you can fix it, and you will find that the IOL becomes centered whatsoever. So the second, we came out with a novel trocar-assisted intraocular and capsular back fixation, which was initially, was used to repair the iridodialysis by Dr. Priya Narang et al. So we used it to make it a trocar-guided IOL capsular bag fixation. So now what is done in this is, it makes life very easy. The first step which is involved is, in this, the brief history was that 65-year-old pseudophakic patient had a blunt trauma, and the IOL back complex had anterior chamber subluxation. So the plan is to use simple needle manipulation using trocar to make fixation simple. Now what is done is you will find that it is anteriorly subluxated. The first step in this is to create a Hoffman's, reverse Hoffman's pocket. Once that is done, and then you can use the 25 gauge trocar at the limbus. Now when this is used at the limbus, as was used by Priya Narang et al. So this makes life very easy. At this difficult angle, you can easily push it in. It acts as a guide, and there is so much of stability in it. And once you are able to push it in without any problem whatsoever, you can definitely railroad it. And this is an unedited video, so this makes life so much easy at all angles, at all, whether it's a deep set eye or you can see again, it's going in, and then you take it in from the other side, and without any issue whatsoever, it goes in without any problem whatsoever, because it acts as a guide and it doesn't let the needle astray left, right and center. There is no entrapment of, the cornea also, because with difficult angles, the tunnel, the corneal tissue gets entrapped in it and it becomes very difficult. So you will realize that once you are able to center it and, pulling it, applying the suture, and the IOL is well centered. So double scleral fixation should be done because UBM remains imperfect even if it happens to be a single with a blunt injury. The second part is dead bag syndrome. I'll just talk about it because you will find that in non-traumatic capsule rupture without any predisposing factor, the bag is clear, the capsule is clear, and still you have subluxated. So the bag is delicate, floppy, and it is unable to support the IOL. It's a clear bag. The subluxation occurs to the peripheral defect while the capsular bag itself was well centered. Spontaneous capsule rupture in the bag IOL dislocation, inferior dislocation through a peripheral posterior capsular defect, and there's a nasal zonulysis. So this is how it appears. Has anybody, Dr. Gaurav, Dr. Amar sir, have you come across this dead bag syndrome in your practice? I saw one patient who had it. This dead bag syndrome, no fibrosis of the anterior capsule, and the bag and the IOL had pierced and it had dislocated. So this is something which we need to talk about. So concluding that we should know the predisposition for IOL bag complex subluxations, use measures for preventing IOL bag complex subluxation, use trocar guided fixation, use double scleral fixation, UBM as a guide, supine position, anterior capsular polishing helps. Thank you very much.
Wonderful, Dr. Rohit, and thank you for taking out all those points. And we do have Dr. Amar, who's accepted to share a couple of more interesting videos with us, because Dr. Namrata is not able to make it for the
Audiovisual?
session.
Yeah, okay. So I thought we have some more time there. So I thought we'll have one video and then we can keep it for discussion, okay? Look at this particular patient. This patient was operated in Iran. It's an Iraq patient in which they had put an ACIOL, phakic IOL. Now, from there the patient obviously is from Iraq, so came back to Iraq. Some years later developed endothelial decompensation, cataract, peripheral anterior synechiae, and a closed angle glaucoma. So now the doctor from Iraq, who's a leading ophthalmologist there, referred this case to me. You can see now I'm taking off the epithelium to see better. Look at the peripheral anterior synechiae on the anterior segment OCT. And you can see this is the anterior chamber phakic IOL. Look how mobile it is. That's why this patient will develop this problem. So the first thing I thought was, let me bisect that phakic IOL and explant it. So far so good. I took out one half. Now I've taken out the second half. Now you can see there's a membrane present in the lens. The mistake I did was, I thought let me take off that membrane. And here the problem started, because when I pulled out the membrane, I didn't realize at that time, somewhere I've ripped open the capsule. So now I can't find the capsule. The lens is subluxed now, and you can see I'm removing everything there, but obviously there's no capsule. Once you don't have that, I thought, okay, I'm stuck now. Let me see what I can do. I thought, let me implant the lens in the sulcus type, but I realized that lens is going down. You can see the IOL leading haptic in the vitreous. So I know now the only solution I have is to do a glued IOL. So you see I made my 2 scleral flaps. I'm now making my 22 gauge sclerotomy 1 millimeter behind the limbus. Now my next step is to do a vitrectomy. I've got a trocar AC maintainer, and I advise everyone to move to a trocar AC maintainer. The same retinal trocar can go in the anterior chamber, ½ millimeter from the limbus, going through the sclera. But the advantage is you know where the cannula is, rather than when it's in the pars plana. Once I've done vitrectomy, I'm now going to catch the haptic, and I'm going to do the handshake technique again. So you see I'm transferring it from one haptic to the other, catching the tip of the haptic and externalizing. So far so good. Now I go in for my handshake technique. So you see now I'm transferring it again from one hand to the other. This is the no assistant technique also which we use, and both haptics are externalized. Once both haptics are externalized, I tuck the haptics into the pockets of Charier's 26 gauge needle creates that. Now I have to do the pupilloplasty. Those of you who haven't mastered this, please go back and start this. It's a very simple procedure, single pass, 4th row pupilloplasty. So here you can see I'm doing that, making the principle that my pupil has to become smaller. Now notice here, there are peripheral anterior synechiae. If you don't break those synechiae, when I'm putting my graft inside, that air will not fill in that particular area. So now my next step is to break those peripheral anterior synechiae, and in the bargain you notice I have created an iridodialysis. I don't mind this because in this case I know if I don't create and break that synechiae, this patient will never become all right. But now once you have that, I have to do a trocar assisted iridodialysis like how Rohit showed you. So where is the trocar fixed? Right opposite the area of the iridodialysis. Now you take a double armed proline suture that goes through the iris, comes out through the sclera. That's the one arm. Then the second arm goes through the iris again, comes out through the sclera. You can see there, and it's coming out under the flap area. Now all I need to do is pull on both ends. And when you pull on both ends, you'll notice, see how when I pull, the iridodialysis will get repaired. You can see that repair. But remember one problem is there. When I pulled it on one side, my iris also has gone off to one side. So what you do now is combine it with a 4th row pupilloplasty. This is the twofold technique. I'm combining the trocar assisted iridodialysis with the 4th row pupilloplasty. Now watch my Perkins image, bang centered. So far so good. Now I'm extremely happy. All I need to do is shift to air. Once I've done air inside, now I remove the endothelium, Descemet's complex, take my PDEC graft, pre-Descemet's endothelial graft, inject it inside, and I think I should be quite happy about it. So you see now the graft injected inside. Now the problem in such cases is, look at the patient post-operative day 1, and I'm extremely happy about it. When I saw the patient later, because that air was in the eye, I got a heart attack because pre-operatively was PL, post-operatively was still counting figure 4 meter though the graft was clear. Now I was scratching my brain and saying, why is this patient not seeing? Remember, this patient is an Iraqi patient, gone all the way to Iran for phakic IOL, come back to Iraq, and now come to me. So there is no way this patient can go back to Iraq and come back. Now I realize my biggest mistake was I had messed up in the IOL power calculation. Now I don't know what to do. So please remember, this is just 1 week after the glued IOL, after pinhole pupiloplasty, and after PDEC. But I had no choice. I had to take the patient back to the operation theater. He's -10 now. Now my problem is, I've got a pinhole pupiloplasty. I have to first of all break the pinhole pupiloplasty. So I'm breaking it with iris hooks. Now I have to dislodge the glued IOL. And remember, all of you ladies and gentlemen, there's a PDEC graft inside the eye. Okay? So there's an endothelial graft inside the eye, and my heart is really scared right now. So now I see I'm carefully explanting this IOL. I'm making a scleral incision there, tunnel incision, and I've explanted it. Now I'm going to re-implant a fresh new IOL of the correct power and gluing it inside. Once I have done that, I again have to do a pupiloplasty. Remember that we did a pupiloplasty, I had to break it. So after vitrectomy, I'm now going to do again a pupiloplasty. Now watch carefully, I'm doing it on one side. Now I'm doing it on the other side. Remember, there's just 1 week back, we had done a PDEC graft. Now look carefully. There, I got a heart attack again. You can see that PDEC graft there. So I thought, let me not test my luck anymore. After this gets fixed, now I say enough is enough. I'm just clearing up this pupil area there. And you can see there the Purkinje image P1. Look at the inverted Purkinje image, that is P4. Don't worry about that. But touch wood, the advantage in this whole surgery, if you notice, is my PDEC graft has not dislodged. And that's the big advantage of PDEC. So now I fix my glue. Now the question is, post-operatively, patient improved to 612. So if you see pre-operatively, patient was PL. We did anterior chamber phakic oil explantation. We did the glued IOL. We did the pinhole pupiloplasty. We did the PDEC, but made a mistake in the IOL power calculation. So we had to do a glued IOL exchange and again do a 4th row pupiloplasty. The patient vision improved to 612. Saying that, ladies and gentlemen, I'd like to thank Kumar doctor and the rest of you all for coming for this final session of ours. Thank you very much. Gaurav?
It was phenomenal, sir, and only you could have done this. I mean, I was thinking that you're going to let it be with that -10 and find some other way of dealing with it, but going back and then it requires a lot of courage and skill both. And I wanted to ask you, you mentioned that it's only because it's PDEC that it stayed there. Can you tell the audience about why PDEC is your preferred?
It's a very good question. You see, actually, if you see bubbling rates, which I have, to be honest to you, we don't rebubble at all. I mean, very rarely I would remember a case when I'm doing rebubbling. The reason is very simple. In DSEC, please understand, you're taking endothelium, desmase, and the stroma, which is about 100 microns. So if you take a 500 micron cornea, you're adding another 100. 600 micron, it has to pump more. In DMEC, you're taking 15 and putting 15 back because it's desmase and endothelium, very good. The problem in DMEC is the donor has to be 40, 50 years and above. In PDEC, we're having endothelium, desmase, and DUA, which is another 10 micron. So about 25 micron. But the big advantage is any donor age. We don't go above 35. I at least don't look at any patient for PDEC above 35. I use a 9-month-old donor. Beautiful it'll be. The second big advantage in PDEC is because the DUA's layer is there, it splits the tissue. It's like, let's say Chitra's hand has got a fracture and I've got a splint here in a fracture. Doesn't matter. Okay? But imagine if there's a splint there, that remains firm. That's the big advantage of PDEC. Another thing in PDEC, remember, you have got a DUA's layer and you're sticking again to a DUA's layer on the top. And that's where I feel the rebubblings don't happen, because once fixed, it sticks there. So these are the reasons why we...
So I think we are just in time, 1 minute left, and we have a lot of people from the next session. Any final word, Dr. Rohit?
Dr. Gaurav, your preferred is glued or Yamane, and why glued?
So we do glued at our center more often. We are still not doing as much Yamane. We've tested it out, but we are still waiting to see some more long-term studies, because Yamane has shown few kind of funny complications as well. Although it's much easier to do and more straightforward and looks very elegant as well. But there have been haptic issues with Yamane which are not seen with glued really. Yeah. So we are continuing to do glued at our center. Yes.
Thank you. I think we are right on time. Yeah. Thank you everybody for making it. And I would like to thank Dr. Amar, Dr. Gaurav, and Dr. Chitra, and Dr. Kumar, and myself also for being here.